Hey everyone, I'm your host Adrian. We do content like this weekly, so hit the subscribe button and ring the bell to get notified. If you want more content like this, click the like button and please leave a comment. Thanks again for watching. Let's just start off by welcoming everyone in today's live class. It's presented by the all-new Rupa University, the best way to learn about specialty lab work from industry experts. My name is Adrian Martinez, and as always, I will be your host for this afternoon session. Today, we have a very, very special guest and Dr. Laura Neville of Doctors Data here to show us how to use the Hue Map to test, optimize detoxification and breast health. Before jumping in, a couple of quick housekeeping items. Everyone joining will be muted by default, but don't fret. If you have any questions, please use that Q&A button in the bottom of your menu bar. And we will host a live Q&A session at the end of the presentation. Immediately following Q&A, yours truly will show you exactly how to order this test directly on Rupa Health. And if you have to jump early, no worries at all. We are recording this session as we always do, and you'll be able to find it all on rupauniversity.com in the coming days, as well as we'll go ahead and send out the recording as well as the slides once we've had the opportunity to edit it all. And additionally, if you are a fan of this type of content, be sure to check out rupauniversity.com to get access to all the previous sessions that we have done. So with that, let's go ahead and jump in. I'd like to introduce Dr. Laura Neville. Dr. Neville graduated from the National University of Naturopathic Medicine and maintains a private practice in Portland, Oregon, with a focus on endocrine health, including type 1 diabetes, Hashimoto's, and hormone optimization throughout the female lifespan. She sits on the advisory board for Hormone University, providing evidence-based alternative medicine research and clinical expertise. Dr. Neville is also a staff physician at Doctors Data, where she writes, researches, and consults with physicians around the world on complex cases. She's a frequent speaker at professional conferences around the country on the topics of women's health, testing, methodologies, brain health, and type 1 diabetes. Thanks so much for joining us today, Dr. Neville. I'll go ahead and let you take it from here.
All right. Thank you so much, Adrian, and thank you to Rupa Health. You guys do amazing work here. So I'm going to jump right in. This is the hormone and urinary metabolites assessment profile. This is a fairly dense presentation, I will warn you, but have no fear. What I'm going to do is kind of go down the rabbit hole with you all, and then at the end, I'm going to pull back, and I really hope that you don't feel overwhelmed at that point, that things look a little bit more clear to you. So let's get started here. Here's our story outline today. We have some different chapters. We're going to be talking about breast health risk. Specifically today, I'm focusing on breast cancer. I'll talk about the urinary hormone metabolism testing that we have. We'll look at a certain patient case, an actual patient of mine under disguise, and then estrogen, progesterone, androgen, corticoids. We're going to go through all of the neighborhoods, look at the metabolism of each one of those and see how that's related to breast health. And then look at a treatment plan. We'll hopefully have time for Q&A. That's why I'm going to keep going at a good pace here. So certain breast problems can present. Again, today I'm focusing on breast cancer. So we've got uncontrollable risk factors here just to take note of. Again,
Dr. Neville, I don't think you're sharing your screen yet.
Oh, here we go. Okay, there we go.
Perfect.
All right. So what I mentioned, again, the HuMAP test, we're going to go through all of these things today as our outline. Again, all of the breast problems that can present, but today I'm specifically focusing on breast cancer. So uncontrollable risk factors, the greater the age seems to be the higher the risk. We have tall stature, interestingly, so people above or women above 5'9" have increased likelihood over those that are less than 5'3", interestingly. So definitely reproductive history can play into this. Having dense breasts, there's more connective tissue there than fatty tissue. For some reason, that increases risk. Certainly, history, family history, or personal history of breast or ovarian cancer. And then exposure to toxins, specifically DES, has been pointed out, but I know in the coming years, there's going to be a lot more research on all of the different toxicity factors that are involved. So these are the controllable ones, not being physically active, being overweight or having obesity after menopause, higher endogenous hormone levels or estrogen levels, Androgens have also been implicated, and that gets a little bit more complicated, and I'll talk about that as we move forward. So certainly taking hormones in supplemental form, and that is specifically the progestins, or the combination of estrogen and progestin. Insulin pathways that become irregular, so insulin resistance, leptin resistance, metabolic syndrome, all of that type of subject matter. Drinking alcohol, also night shift work has been associated with a greater increase of breast cancer risk. So here's what we know so far. Estrogen is certainly vastly important for health. It has over 400 different functions in the body, and so we certainly need estrogen. But I thought the title of this paper was somewhat eye-catching because it's basically saying it's a necessary evil for human health. I wouldn't so much call it evil. However, we do have to really respect estrogen and keep in mind that, you know, in a way, we need to tame it. We need to make sure it's working appropriately because it can become somewhat naughty in the body. Okay. I liked this study also. This was from 2018, and they were actually looking at an estrogen-related lifestyle score. So not so much what is the level of endogenous estrogen, but what are the factors that a person may be doing in their life that are increasing estrogen levels. So things like, you know, an estrogenic diet, low alcohol consumption, or alcohol consumption in general, higher body weight, lower physical activity. These are all factors that lead to higher endogenous levels, but it's actually not the estrogen that they're particularly looking at here. They're looking at the lifestyle behind where that occurs. We also have to keep in mind that when we're talking about estrogen, we are talking about endogenous estrogen, but cumulatively, we're thinking about total estrogen burden. So maybe additional estrogen-based therapies, phytoestrogens, arguably, I favor those, but we have to keep that in mind. And certainly xenoestrogens. This is probably one of the biggest factors that we are facing and our patients are facing today. Now, this is a study, just an infographic that I liked a lot. It was a figure looking at two different but complementary pathways that together are really likely to contribute to the carcinogenicity of estrogen. So we've got metabolism on the left-hand side. And these are the metabolites. I used to think, oh, well, you know, these are just breaking down and leaving the body, but there's actually biologic impact here. So we have to keep that in mind. We have some more favorable metabolites. We have less favorable metabolites. We can look at that. But then also, how is the estrogen responding at the receptor site? So these two different things that we need to keep in mind. Now, this study tells us that estrogen is stimulatory to breast cancer growth, and that the androgens are actually inhibitory. However, we're pointing the finger more at the ability of some of these estrogens, testosterone and androstenedione. Here you see they have the aromatase enzyme that's moving them more towards estradiol, and that potentially is actually the problem with the androgens. So we'll take some more a closer look at this as we continue on. I do want to just remind everyone, and I think, you know, we're all still suffering with the backlash of the Women's Health Initiative when it was first published, and kind of the misinterpretation, the misidentified data that came from that. So, you know, updated analysis that we do not see an increased risk of breast cancer with estrogen alone. I just want to remind everyone of that. And this was interesting. So now we're at the point where we're looking at the breakdown products. We've seen that estrogen is stimulatory, androgens not so, they're inhibitory. But then when we look at the breakdown product, we're starting to get these studies that are looking at things like the 2-hydroxy pathway and the 4-hydroxy pathway and comparing those. And they're seeing, at least in this study, a premenopausal woman who has higher levels of the 4-hydroxy estradiol level has a higher risk of breast cancer. So it's not just the endogenous alone that we need to look at. We also may want to look at these breakdown products. Now, I should have had this slide just one earlier, but along the kind of risk factor for hormone replacement and breast cancer, this study is really interesting. So this was funded by the NIH. It was posted and came out online in May of this year. It has not been peer reviewed. I haven't heard a lot of people talking about this study. I feel like we all should be talking about it because it is looking at estrogen monotherapy showing an overall risk reduction in mortality, 20%. And that's with oral or transdermal preparations, not with conjugated equine estrogen. They're also showing from this study of 7 million women risk reductions for all of the cancers they studied in this paper: breast cancer, lung, endometrial, and colorectal, all of those. So very interesting, very different than, you know, the 2002 big scare of, okay, stop prescribing estrogen, stop prescribing hormones. Oral estrogen showed a slight increased risk of ischemic heart disease, but not observed if that was a low dose. And then the combination therapy, in this title, it's talking about progestogens. That was progestins that they were looking at. So we certainly know, we've seen that does increase breast cancer risk. Okay, so just vastly overwhelming new data coming out there. And let's see. Oh yeah, this is a new one. Got my slides mixed up there. So estrogen metabolites in postmenopausal women. So we're looking at lower urinary or unconjugated estrogen and more extensive 2-hydroxylation reduced breast cancer risk. Okay, they saw a higher total metabolite and estrogen levels in postmenopausal women in the United States when compared to women in Shanghai. So that's maybe partially explaining the higher breast cancer risk here in the United States. This was a review study looking at 3 prospective studies. They were using LCMS, or mass spectrometry liquid chromatography, which is important. That type of lab testing is much more sensitive and specific for these teeny little metabolites that we're testing. A lot of studies in the past were using immunoassay, which just isn't very sensitive at picking up some of these teeny tiny molecules. So that's part of the problem with some of the research, but always look for that. Make sure the study is using LCMS to really rely on what you're seeing. But this was looking at enhanced 2-hydroxylation of those parent estrogens, and that was associated with the reduced risk in postmenopausal breast cancer. So we're seeing that over and over and over again. So now I want to introduce you to the urinary hormone and metabolite test. So these are the areas when you might consider doing this type of testing. Somewhat of, I think of this almost like a fingerprint, right? Metabolism is going to be inherently unique to everyone. There are so many factors that go into how is that body breaking down hormones. And so, you know, having this tool is a very unique opportunity to be able to see into, like, under the hood, if you will. Patients aren't going to necessarily notice these types of symptoms, but you'll be able to assess potentially risk right there. Now, I want to point out here, you know, there's many different types of ways to test for hormones. Urine is really the only one at this point in practice, besides a research setting, that you can look at the metabolism of endogenous or supplemented hormones, okay? And we also have to keep in mind that the urinary metabolism, we're looking at the end point, what's leaving the body. It may not be necessarily reflective of what's going on at the tissue site. And I think that's probably one of the biggest things to understand. So, important point, this isn't just me saying this, but certainly research out there is saying, hey, make sure, you know, you understand that this may not be directly reflective of what's happening at the tissue. And so don't make that large jump, that assumption. If someone is using hormone replacement and we want to know, hey, is this dose correct? That may be a different test that we need to look at, specifically saliva. So this is how I think through, you know, which medium shall I choose? Which one should I choose for the patient in front of me? If I have my pick and I want to know, you know, what is the bioavailable tissue level of what's happening for my patient, I'm choosing saliva if I get my choice. If they are using topical hormone supplementation, especially progesterone and testosterone, because those are more, they're fatty, they're even more fatty substances than even estrogen. They're more polar. I'm going to be using saliva to track the dosage of that. However, if I get to the point where I have concern, and with doctors' data, you can use the comprehensive profile or the comprehensive plus. The plus is looking at various, all the different types of estrogen. So certainly something to consider if you're concerned about breast cancer. This is the one I would choose. Now, if I'm also concerned about overall risk, breast cancer, organ health, endogenous metabolism, exogenous metabolism, detoxification pathways, enzyme function, that's when I'm going to Hue Map. So sometimes I will use these side by side together. I may start with one and then use the other one later, but that's how my thought process is. And I just wanted to share that with you because I know that part can be really confusing. So here is what the Hue Map looks like. This is the first page. This is the summary page. And really what we're showing you here with this kind of half moon portion that I've blown out here, these are what we see as the clinically relevant markers. They're color coded to your patient's specific levels. Okay, so it's a dynamic report that's showing you this. It's going to look different for every patient. So you get this kind of at a glance format on the summary page. I know you're busy. I'm busy too in clinical practice. We need kind of like, give me the goods, give me the like main stuff right away. That's what this summary page is. Okay, so it's going to save you a lot of time. This is a very, very long report. You can go down the rabbit hole and, look at everything. But if you are really pressed for time, you need to get big picture right away. This is the summary page. Arguably, this part is the estrogen. I would say this is probably one of the most helpful pieces clinically that you're going to have. So at this point, we're comparing phase 1 of the 2-hydroxy pathway, the safer pathway, versus the more dangerous pathway as far as breast health is concerned and risk. We're also looking at the 16-hydroxy pathway. And then I tend to think of this, my colleagues and I kind of came up with this, it looks like a car in the shop, lifted up. And I think of this safer pathway, this is like a Toyota Prius, super safe, really good, nothing scary about this car. This is a race car. This 4-hydroxy path is a little more dangerous. And I want to make sure that phase 1 is moving on to phase 2 through the COMT enzyme. And so I want these back tires to have some weight in them. You can see in this report, they're blue, they're kind of cool, they're lower, more depleted levels. So I've got a lot of power in the front and not in the back, especially for the race car, because race cars are rear wheel drive for a reason. They have to spread out that power to make it less dangerous. So in my preference here, I would really like to see these numbers have a little bit more heat, a little bit more, green, red, yellow in them rather than this blue color. So bottom line, it's giving you the methylation potential. And then this part is just showing you the percentage of each. So arguably in this case, you really want to bring down the 4-hydroxy pathway here. Okay, I hope that car analogy helps because that part can be, I think, a little bit confusing when you first look at it. We're also pointing out just the cortisol cortisone plotted on the same graph so you can quickly identify the relationship to one another. And you can also see the activity of the enzyme here, 11 beta HSD, and you can see kind of where is it favoring cortisol, cortisone, get the activity of that. We are also pointing out the key relationships of some enzymes that you really want to pay attention to as far as breast health. So we've got 5-alpha reductase, usually a risk factor. You don't want a lot of activity in that enzyme, as is the same for aromatase. You don't want a lot there. And you'll see this in 2 different areas. And then COMT activity. This one's great. We've got a lot going on there. So that's a benefit. Okay, so that's an overall look. I'm going to introduce you to my patient. I'm going to call her Gigi. And she came in, mind you, she's 50 years old. She looks really good. I think she's got a really good skincare regimen here. So she wanted a hormone consult. She's been having all of these symptoms and, you can see them all listed here. Those are very classic perimenopausal, kind of menopausal symptoms. So nothing super surprising there, but just to paint, a whole picture for you. Height 5'10", remember, that's a risk factor actually. Higher tall stature. Her past medical history, she has hypertension, it's well managed. Hashimoto's hypothyroidism. She was on a BCP for 20 years, though she stopped 5 years ago, so that actually reduces her risk. She is happily married to this lovely gentleman right here. She's in the film industry, so she's got a lot of stress. She is physically active for her job, but she's not able to exercise outside of that. And she's really gained quite a bit of weight in the last year or two. She's trying to eat healthy, but she's relying on fast food 2 to 3 times a week from that really busy schedule that she has at work. She's stressed out. She's managing that with alcohol at 10 drinks per week. She's working occasional night shifts. Her mother was diagnosed with breast cancer at 70, and then she's got a family history of metabolic stuff going on. So constipation's also there. She's not sleeping a lot. She doesn't have very much energy, high stress. Her blood labs, for the most part, look decent. She does have dense breast tissue, so during mammograms, she's usually referred to ultrasound for follow-up. However, in the past, they haven't found anything significant. So these are the big kind of things that jump out to me now that we know about the uncontrollable and the controllable risk factors. It's really that, these up here are the uncontrollable ones. Can't do a whole lot about that, but I do want to make note of it. These are the ones that I can really do something. Okay, so there's just, I want to point out here that there's so much that we can do and can be implemented in a very strategic way so that our patients have the best outcomes. So let's dive into specifically the estrogen metabolism now. So this is Gigi's estrogen metabolism. This is a patient of mine. And so again, we're just looking at the summary page. You've already seen, these are the important clinical markers, the estrogens, the corticoids, and the key enzyme relationships. This is the second page of the test. This is also dynamically reported. So you're getting a big picture view of all of the different steroid metabolism in the different neighborhoods. So the progesterone neighborhood, the corticoids, the androgens, and the estrogens. So obviously I'm going to zoom in right here. And let's start with those and let's go through each neighborhood. I'm going to pull out what we need to consider as far as breast health for this patient. So right off the bat, we notice her estrone in urine is elevated. This is the unconjugated or parent hormone. Those are interchangeable terms, is elevated. And that has been correlated with an increased risk of breast cancer. So if I were going in here and I wanted to reduce that, I would pinpoint this enzyme here. I know it's really small, I apologize about that, but this is the aromatase enzyme. So I'm going to consider trying to calm that aromatase enzyme down. I may also want to push a little bit more into this 2-hydroxy pathway. You can see the estradiol is a little bit low on that side. And then maybe a little less of this 4-hydroxy pathway, right? I don't want so much race car. I want more Toyota Prius. I also want to make sure this race car is rear-wheel drive so that I can keep it stable and safe. I want to methylate. I want the COMT enzyme to work well. Okay, so that means I'm going to start with this aromatase. So it's converting androstenedione to estrone. We see that as being an issue potentially in this case, and then testosterone to estradiol. Okay, so you can have many polymorphisms here. This is well known for, carcinogenic potential. This is all of the research that I could find on how to lower and downregulate aromatase. I'm highlighting here for you the ones that I like and prefer as far as treatment, especially for this patient, because, and you'll see as I keep going throughout this presentation, that these items pop up again and again and again. So if I can use resveratrol to modulate 5 different enzymes that are going to be beneficial, of course, I get like a 5-for-1 there. I'm going to choose that for my patient. Try to make things more simple, but I do want you to just see the overall amount of things that you could choose from and pick your favorites, but those are my favorites. And then how do I upregulate aromatase? And I'm working backwards here. I don't want to do this. However, you can see that these are all part of my patient's story. So I can help her to work and not do these things in order to lower aromatase at the same time. Okay, so I'm just keeping track of all of these things by highlighting them. And I'm going to pull this together at the end, but I just want to kind of walk you through my whole thought process and how I interpret this test. And then this is the 17-beta HSD enzyme. So it's really converting between estrone and estradiol. Okay, in this case, I'm really happy with this estradiol level. I don't feel like, and remember, these are endogenous levels reflected in the urine. So there isn't hormone replacement going on, which kind of, that's a whole other thing that we can talk about. So I'm happy with that. I don't feel like I need to modulate that, but it is something to consider. HSD has been implicated in breast cancer, specifically HSD 17 beta 1, high amount of that in breast tumors, and higher amount of that has been correlated with an increased relapse in breast cancer. Okay, so if I just say, for instance, that I did want to modulate that, downregulation of that enzyme might include licorice or quercetin or any of these flavonoids of phytoestrogens. In my patient's case, just pretend I wanted to downregulate that, I might choose quercetin or these flavonoids. She has a history of hypertension, so I'm probably not going to jump for that licorice. So phase 1 detoxification, just in general. Now we've seen the parent hormones in the urine. Now we're going to start breaking these down. So this is phase 1. This process is responsible for breaking down the fat-soluble toxins. So these are all types of toxins, not just hormones. They're all going through this process. The problem with phase 1 is that it has the potential to create a lot of oxidative damage. When we get partway through that and we stop, we have a lot of reactive oxygen species present. So we want to make sure that we don't get to phase 1 without moving through phase 2. That's really important. So overall, this is a photo of the different enzymes and cofactors that are necessary. And then if you do get to this intermediate metabolite area and you need support, these are the things that are going to help to dampen that damage. Moving on to phase 2 will certainly do that, but this is where the body has backup ways of managing, all of these things when they don't move through perfectly. Okay, and then this is specific to our patient. These are the catechol estrogens. These are the phase 1 estrogens. So we've got the unconjugated ones here, and they've been broken down either into 16, 2-hydroxy, or 4-hydroxy. Okay. I think there's not so much more I want to say here, but the 2-hydroxy overall, we see that as the safest one. You've seen the research on that. 4 seems to have the most potential damage to DNA. 16 also has been implicated. And so, the CYP1A1 enzyme is the one that pushes the 2 pathway. So we usually always want this, okay? But we do have to remember, even in the safer pathway, it can get stuck here. And if it's not methylated, you still have reactive oxygen species happening. So this isn't all perfect. However, it's a step in the right direction. And this study, I know you've probably all heard of diindolylmethane or DIM as a treatment for optimizing estrogen metabolism. That's because of studies like this that show that diindolylmethane is increasing that 2-hydroxylation pathway. So something to keep in mind, that can increase the enzyme that helps support that CYP1A1. This was a clinical trial looking at estrogen metabolism in flax seeds. So we were seeing an increase in the 2-hydroxyestrone with the flaxseed. So I always find it hilarious that they used a flax muffin in this study. I don't know why they couldn't just give the seeds, but regardless. Okay, this is also a study looking at a reduction in breast cancer, daily green tea. So they had 119 premenopausal women. They saw a lower urinary estrogen and metabolites, a lower 16 pathway. So that's cool. I know my patient, she's postmenopausal, but she has a high 16 pathway. So arguably, I'm not going to be, even if this study was in premenopausal women, I feel safe giving this to postmenopausal women. Postmenopausal women, we saw lower estrone and estradiol in the urine with green tea intake. Okay, so this is how you upregulate CYP1A1. You already know diindolylmethane comes from the cruciferous vegetables. Rosemary, resveratrol, green and black tea. I'm highlighting the ones I like, the ones that I find easy to implement in clinical practice, and I'm going to pull those in at the end. This is how you downregulate this enzyme. So interestingly, there are a lot of healthy things on this list. So you might be thinking, why the heck would we want to downregulate CYP1A1? These are, you want both up and down regulation. So the body has backup ways. If COMT and phase 2 are not working appropriately, this is almost like a modulating, tonifying way to help slow down CYP1A1, allow the body to catch up, get those antioxidants on board, clean some of that up, and do less damage. Okay, so you always want both of these happening. You want the body to be able to have this option. I truly think this is showing us the innate intelligence of the body to heal itself, to tonify itself. And we are never going to come up with the perfect, medication or one supplement that's going to do all of the work that the body's constantly doing. And so I want the plethora of things for my patient to have. These lists are sometimes tricky because they're not so linear. I know we like to have, a list and a protocol, but these are biphasic dose-dependent actions sometimes. Green tea is both upregulating and downregulating. Turmeric at certain doses, upregulating, downregulating. So very interesting, these biphasic modulators. Now we have CYP1B1. This is moving towards the 4-hydroxy pathway, and higher, incidence of this in tumor tissue. So in general, not what we want. We don't want to move in this direction. So these are the ways that you upregulate it: insulin resistance, inflammation. I'm thinking my patient has some of this, so I'm going to help her work to get rid of that, to dampen that. And then this is how you downregulate it. Plenty of beautiful things in here. The Apiaceae vegetable family, resveratrol, again, you see that one pop up all of the time. Lycopene, so tomatoes, carrots, watermelon, and then rooibos tea, a lot of those red pigment type foods. So I'm taking note of these. I'm highlighting them because these are the things I'm going to be using for her. CYP3A4 is moving towards 16 the pathway. And so I want to probably downregulate this. Remember, we saw quite a bit for her. So green tea does this, but these are the way that you upregulate this. I don't necessarily want these. I want to downregulate. This slide is just an entire list of polyphenols. Amazing. We can get this by eating fruits and vegetables. We don't have to, Christ and luteolin, like they're, give 50 supplements. But if we're looking at these, it's overwhelmingly present that fruits and vegetables are reducing cancer risk. We know that, but to see it in detail like this, I think is really helpful. Resveratrol shows up again on this one. So now we're moving on to phase 2 detoxification. So this is breaking down enzymes into water-soluble compounds so that we can get them out of the body, make them less toxic. And we're accomplishing this through these different types of reactions that you see here: glucuronidation, sulfation, glutathionization, acetylation, amino acid conjugation, and methylation. Methylation is specific to estrogen. So this is what that looks like. We've got our phase 1 catechol estrogens here. We want to continue moving them, give more real stability especially for the race car, but even for the Prius. Okay, so if we are methylating them, that is wonderful. We're keeping them stable. We're getting them out of the body. But if we're oxidizing them, meaning we're not methylating, now we have some trouble. We're creating potentially some quinone and semiquinones, which are damaging to the body and can damage the DNA. So this is our patient. And again, COMT is like the friendliest character that we have in this entire story. So we just want more of that. We want to make sure that that's working appropriately. So this is a figure showing where the catechol estrogen methylation, which is catalyzed by COMT, and the estrogen semiquinones and quinones react with glutathione and where that reaction occurs. So you've got your COMT here, hopefully moving in that direction, but if it doesn't, we've got semiquinones. If we don't have glutathione conjugation, we can get these quinones and potentially cause damage. I thought this was a very interesting study I found on the equine estrogen metabolites of conjugated equine estrogen, something like Premarin, they were actually showing this to inhibit the protective phase 2 enzymes. So they were saying, hey, be really cautious just with conjugated equine in general. You're potentially causing some increased risk of breast cancer, but specifically for the women who are homozygous for the polymorphic variant of COMT, that's actually going to further make that COMT just very sensitive to damage from these estrogen metabolites. So how do you upregulate COMT? With food-based things, cruciferous vegetables, resveratrol, rooibos tea. You see these come up again and again and again. The cofactors and methyl donors are listed here too. And how do you damage COMT? High sucrose diet. My patient's probably dealing with some of that, and some leptin resistance. Yeah, probably dealing with some of that. So I want to get after that. I also want to just educate her about some of the toxicity components. Bisphenol and the PCBs can really damage COMT. Now, this is called phase 3 of elimination. We're looking at, we've got through phase 1, phase 2. We still have to get this water-soluble toxin out of the liver into the bile or blood, moved from the blood into the kidneys or moved from the bile into the digestive tract. So as you can guess, this whole success of this whole process is only as good as the elimination system. So we want to make sure constipation and digestion, constipation is not there. It is for this patient. So these are typically the things I work on first. Make sure this is happening arguably prior to doing anything else, because if you are upregulating her CYP enzymes in phase 1, you're dumping all these reactive oxygen species, things aren't able to move out of the body. So magnesium, interestingly, also supports COMT. So anytime I see a twofer, I'm going to probably choose that. Okay, so we've talked about estrogen. Let's move on to the progesterone neighborhood. This one is a little bit more challenging to talk about. There are so many complex factors contributing to the challenge of understanding progesterone's role in breast cancer specifically. So first of all, progesterone and estrogen are paracrine in nature. They depend on one another. So studying them separately sometimes really gets us into trouble. There's such a huge variation in these levels, especially if you're talking about premenopausal women or pregnancy, that gets difficult in the research if we're not using the same timing. The sensitive assays have been a problem in the history using radioimmune assay or immunoassay. Now that we have LCMS, much less of a problem, but still something to consider when you're trying to compare studies from years past. We don't have a lot of data about the progesterone metabolites. And so, there's inconsistent evidence, I'll say. Some studies say that it's increasing proliferation, decreasing, or having no effect. So the jury's probably out, I would say, in the coming years, because there's more research looking at LCMS and these metabolites, we'll have more information. But at this point, we have to be a little bit careful about how we understand that. So I'm sure you've heard of this study. Looks like, am I frozen? Okay, here we go. So breast cancer risk in relation to different types of hormone therapy. You may be well aware that a lot of times the research studies lump progestins and progesterone together, or they call them progestogens, and they're not actually delineating them, which is a big problem because we see marked difference. This study was looking at estrogen plus progestin, increased risk of breast cancer. Estrogen plus progesterone, no increased risk. And progestins were actually invented on the market because we needed more potent progesterone to protect the endometrium from estrogen proliferation. So orally administered progesterone, even in the micronized form, is not very well absorbed. We don't see a lot of that going to the breast tissue, to the brain, to the eyes, to the bones, to the nervous system. So because of that, these progestins came out on the market. Great, now we're protecting the endometrium. The problem is we're now increasing the risk of breast cancer, and breast cancer rates are so far greater than endometrial cancer it's arguably quite silly to be using a progestin in that regard. Progesterone does have beneficial effects. The problem is sometimes we just really have to ramp up that dose to get that protective effect. This study is now old, but probably one of those famous studies out there about the anti-proliferative effects of progesterone. So this was topical progesterone reducing proliferation in benign breast lesions, and it was tracked from topical application to the breast tissue, showing that it was present in the breast tissue, but the serum levels did not rise. Remember, progesterone, very polar. It's really not going to show up in serum levels, even though it's reaching the tissue. So here's the big problem. Just a summary is that we have not a lot of studies looking at endogenous progesterones and the metabolites in breast cancer risk. We've got, this difficulty because they're dependent on one another, estrogen and progesterone. Not all studies are differentiating between progesterone and progestins. And then we have a lack of understanding of transdermal supplementation transport in the body. We're looking in the serum and not finding it and going, what the heck is going on? And then we are also arguably using, I won't go into that, but a lot of estrogen, high dose estrogen, very little progesterone, and going, it's not protecting against proliferation. Well, it's just because we're using excessive estradiol doses in a lot of these studies. Okay. In the past, again, immunoassays were used to look at progesterone levels, and they're just not sensitive enough. So we really need to focus on the LCMS studies. 2020, this study came out looking at the metabolites of progesterones. Remember, there's not a lot of research, but there is some out here for pregnenes. So this one right here, these metabolites retain their double bond. When they move to 4-pregnane, so they're using 5-alpha reductase to reduce this double bond. This is actually the version that goes towards allopregnanolone. We're starting to see some research saying that when the pregnanes are higher than the pregnenes, there's an increased risk of breast cancer. So it's new, but I do think that that's potentially something to look at. Not all labs are reporting the difference between the different types of pregnenolone, but they are right here. If you take a look, we have a difference showing 5-beta versus 5-alpha, what I think is helpful, because if this research really continues, we're going to be seeing that we're really having a preference for the 5-beta. We don't want a lot moving through this 5-alpha reductase and potentially even onto allopregnanolone. We're starting to see these pregnanes, as they're called, higher risk of breast cancer. So just pretend I didn't like that, movement towards 5-alpha. I wanted to reduce 5-alpha reductase. I want to downregulate. These are all the ways that you can do that. Please keep in mind also that these enzymes are functioning in other neighborhoods within the hormone world. And so we're also going to be inhibiting testosterone to 5-alpha DHT, androstenedione to androsterone, and then some of the corticosteroid and cortisol metabolites. So I've just highlighted them for you here. I know you can't read this, it's so tiny, but it does say 5-alpha reductase right there. 5-alpha reductase there, and there. So that's all the places where you're going to affect that. Probably always something that you want in general, but just keep in mind. Now, there were a few studies, 2006 to 2013, that were looking at high dose progesterone. So high dose meaning greater than 200 milligrams each day was increasing that pregnane conversion. And that when that exceeded the pregnenes, we saw an increased risk of breast cancer. And so keep in mind, my argument to protect the breast is you really have to ramp up that oral dose high enough to protect the breast, but then you run into this problem. So we're in this kind of area where we get stuck. I really do believe that with time, we're going to see that topical progesterone is far more protective to the proliferative effects of estrogen to balance that. I know other people do not share that same opinion as me, but I just want to put that out there. I found this was a study that was interesting. There was a very recent study from this year looking at they were treating retinitis pigmentosa. So they were using an ocular progesterone, found that to be much more effective than oral progesterone because so little of that was reaching the eye. Now, arguably, you're putting it right on the eye, but I've seen this over and over with some of the topical studies. It's really accessing the tissue levels much more than oral. So I think that protects against breast cancer. Androgen metabolism. We've got these and the corticoids, and then we'll look at the treatment, okay? Estrogens stimulate, androgens are inhibitory to cell proliferation, and this is happening in both normal and cancer tissues. Interestingly, the BRCA1 gene, that protein binds to the androgen receptor. So it suggests that it may be blunting the androgenic effects and may be part of the reason that that increases the risk of breast cancer. This study found that elevated urinary levels of estrogens and androgens were associated with an increased risk in breast cancer in postmenopausal women. So they said it wasn't just aromatase. They were saying also watch out for that 17 beta HSD moving androstenedione to testosterone, and watch out for 5-alpha reductase moving testosterone to DHT. So not all the studies are going to agree, but we have to kind of decide for ourselves what makes the most sense and be cautious and continue to watch this research. Again, here we're looking, they said androstenedione, yep, that makes sense. It's aromatizing, testosterone's aromatizing. We also need to make sure that we are wary of this 5-alpha reductase moving to DHT and HSD 17 beta. So some studies will really point to aromatase being the main issue. I think that's fair. That is unargued. I think that's probably the most problematic area, although there are other enzymes that also, correlate. So the level of estradiol in breast cancer tissue postmenopausal women is reported to be 10 times higher than what's in their serum. Whereas for people without breast cancer, breast tissue is approximately 4 times higher than the serum level. You guys can see that's why I don't prefer serum to be looking at risk factor for, do you have too much in the tissue? I really prefer saliva for that because you can see that difference. You can catch it earlier. So androgens protect, estrogen proliferates. This study is arguing that this single model might be able to explain breast cancer, prostate cancer, things like that. Not all studies, again, are agreeing. This study was showing urinary testosterone and androstenedione, the aromatizable androgens, to increase risk. So I'm highlighting for you here, this is our actual patient Gigi. I'm highlighting for you all of the studies so far. They're pointing the finger at these enzymes and testosterone, DHT, androstenedione, okay? Or androsterone, excuse me. Now, that's a fair starting point. I think we need to keep an eye on those. At this point, I'm really happy with this patient's androgen levels. They look really beautiful. They're all nice in the green section, right? And then we do want to keep in mind the 5-alpha reductase activity. The lab will point out to you a ratio that will really give you a clue as to how that's functioning. So in this patient, she doesn't have a lot of 5-alpha reductase at play, so you're seeing a low level. Low doesn't mean bad. Red doesn't mean high. Red means, well, in this case it does, but red in general on this test means an abundance of. Blue is depletion or low. This is actually a good thing in this case. So I like to see that. Now, just pretend that that wasn't the case and I wanted to downregulate that. Again, we just saw this, but this is how you do that. All of these wonderful substances here. And then also remember, you are inhibiting progesterone to 5-alpha pregnanediol, probably okay. And then some of these cortisol metabolites, which we haven't talked about yet. Just as a reminder, I'm highlighting, I know that I want to reduce aromatase for this patient. And so you've already seen this. You can argue, so the 17 beta HSD, if you wanted to move that one down, licorice and quercetin. Again, if I wanted to use that in this patient, I'm probably going to avoid the licorice just because of her hypertension history. Now, I don't see research talking about specifically DHT or DHEA, it or DHES in relation to breast cancer. Arguably PCOS, yes, and arguably metabolic syndrome might increase that risk of breast cancer, but it's a little bit roundabout. I don't have a huge problem. This patient had a slightly elevated DHEAS, but if I wanted to address that, I could downregulate it. It's the same things as the past enzyme that we saw. I would avoid a licorice in this case and probably go for the quercetin. Okay, corticoids. This is our last neighborhood. Very little published data on corticoid metabolism. This test is really at the forefront of discovery, okay? So companies like Doctor's Data need to collect info like this and look for patterns along with you. So you are doing cutting edge work by doing this test and helping us to mold the future of what we understand this to mean. So this is what I would say. Do the test, but be cautious about absolute interpretation of it because it gets a little complicated. This is what we can say for sure. Stress increases breast cancer risk. It's probably not arguable. Cortisol is anti-inflammatory. And the salivary diurnal cortisol curve is the best test to assess HPA axis function. So if you are worried about their HPA axis, it's the salivary diurnal cortisol that you want to look at. If we're looking at urinary free cortisol, cortisone, and their metabolites, we're likely looking at something that is reflective of outside issues, outside of the HPA axis. So metabolic issues, insulin resistance, obesity, inflammation, hypothyroidism, something like that. So if you're seeing high levels of those cortisol in the urine or metabolites, focus on those potential causes. So ask the patient, look into inflammation, hypothyroidism, obesity. Don't think that directly going for the HPA axis is going to necessarily change these urinary levels, okay? If you are concerned about that, you may want to reflex to salivary cortisol testing to understand that HPA axis. Now, what we can say, and we do know certainly that salivary diurnal cortisol is linked to many different health issues, arguably breast cancer. We're seeing lower diurnal slopes or flatter curves. Certainly night shift work, flatter curve, less melatonin, higher breast cancer risk. Now, because I think, and I can safely say all of us here are trained to address HPA axis. Like that's just like number one in some of our training, and for good cause. And so because I know you're going to be thinking about the HPA axis regardless of urinary cortisol metabolite levels, you know, for your patient, which is great, I did want to point out this really amazing scheme here, or this little picture from Dr. Williams. And he's pointing out that you can see circadian rhythm, inflammation, glucose regulation, and perceived stress as all modifiable categories of HPA axis stress. And he's pointing out all of these different pieces here. So I think this is just a super helpful thing I wanted to throw in there because I know you're going to be worried about it and trying to help your patient regardless. And also to point out that these are all reactive, except for the perceived stress. That's the anticipatory part of the stress response. So that's for HPA axis. Now, when we're talking about urinary cortisol, we're measuring the free cortisol and free cortisone in the urine. So arguably, you might be able to see things like little spikes that are happening in cortisol throughout the day from things like exercise or coffee consumption, somebody that has hypoglycemic events. You know, these things can lead to cortisol peaks that you may not be able to catch in saliva because you're looking at 4 points throughout the day, right? With urine, you're actually measuring a pooled amount that's sitting in the bladder over hours. And arguably, if the patient is collecting their points without trying not to urinate in between those points, you know, they've got a full bladder that's been collecting the whole day. So it's arguably much more like a 24-hour urine collection. So just, you know, something to consider. Now, if you were concerned about, you know, elevations here, again, I would be pointing to, you know, things outside of the HPA axis. Is there metabolic disturbance here for this patient? Yes, probably insulin resistance, obesity, inflammation, hypothyroidism. We know she has hypothyroidism. And this 11 beta HSD, you know, is modulating cortisol to cortisone. So cortisone being the storage form. This HSD2 is protecting from the aldosterone effects of stress. So again, think about all of those things outside of HP axis, and then maybe reflex back to that testing if you want. Remember also, we saw this diindole methane study that was showing increase in 2-hydroxylation, but I also wanted to point out they actually saw an increase in urinary cortisol, which I found interesting with diindole methane. So it might be something to consider. There was one study I found that's fairly new, 2021, on urinary androgen and glucocorticoid risk for breast cancer. So they found a doubling in the androgens was associated with increased breast cancer risk, specifically the glucocorticoids, and I will highlight them on the next page because they get all these, shortened versions of them, make your eyes cross. And it was the androsterone and what I call OHAN. Those were the androgen metabolites that they were looking at. But again, they also looked at these glucocorticoids, which I haven't seen any other study showing that. So I'm pointing out this one we already knew that was previously stated to be a risk factor, but now we're adding this one. And actually this one, they said there was a 90% increased risk. So pretty big deal. And then as far as the corticoids, I'm highlighting the ones that they found in that study to say, if these increase, that was a risk factor for breast cancer. I'm also pointing out this here, the CYP11B1 enzyme. If you're concerned that, say, this isn't moving appropriately to cortisol, these are the things that can modulate that. Again, I don't see any direct breast cancer risk there, but I did want to point that out because that was the case for this patient, for our patient Gigi. Now, I'm going to briefly go through some other breast risk factors that we haven't really talked about, but these estrogen quinones we've touched a little bit on. Bottom line, if you have more estrogen, you have more potential for these estrogen quinones, especially when methylation is not happening. That can turn those metabolites into quinones or semiquinones and can result in DNA damage, increased risk of breast cancer. Hopefully you are having methylation go just very smoothly and wonderfully, but if you don't, and there's always some of that happens, know that NAC and resveratrol have been shown to reverse that quinone, semiquinones back to catechol estrogen. So that's really cool. I found this study I thought was interesting. They were using nanoemulsifying, this is injected into breast cancer, tamoxifen, and combining that with resveratrol. So pretty cool. That was brand new from this year. So nuclear and mitochondrial DNA is this marker here. So it's 8-hydroxy-2-deoxyguanosine is one of the predominant forms of free radical induced oxidative lesions. It's widely used as a biomarker for oxidative stress. So when you think about oxidative stress, always think about this potential link to carcinogenesis. Our patient had a beautiful level. I'm super happy with that. But if your patient didn't, and there's many, many reasons to create oxidative damage, think about these factors here as helpful components. Glutathione, resveratrol, you see these things come up over and over and over again. NAC, berberine, like we've seen them over and over and over. Increased fruits and vegetables, right? So that's the good news, is that you can treat so many different things in multi-mechanistic ways with fruits and vegetables, with these phytochemicals. Now here's a plot twist in our story. This is our hormone villain, beta-glucuronidase. We see this being a problem because once we have these conjugated estrogens and they're going to pass through the gut to be eliminated, this beta-glucuronidase can deconjugate, basically reverse all that beautiful work that the patients did. And then this unconjugated estrogen can get reabsorbed back into circulation. So we've seen that higher levels of beta-glucuronidase could potentially be a risk factor because we're seeing more levels of circulating estrogens. So this is where you might consider, if you wanted an adjunct test, to utilize stool testing. This is our GI 360 test. It's looking at the microbiome abundance and diversity. You can actually get a dysbiosis index score. And we see for this patient, her level was at 2. So technically that is not dysbiosis. A level above 2 would indicate that. But Really amazing, amazing test of GI360. Our lab actually analyzes more organism identifications on our MALDI-TOF instruments than anyone in the world. So really cool test to add on if you feel like, there's a piece that is missing for you. I cannot say enough about diet and nutrition for breast cancer risk and hormone metabolism. Study from 2018, a 10% increased risk in ultra-processed foods in the diet was associated with greater than 10% increased risk in breast cancer. So 10 greater than 10, that's right there. Right there, if we reduce that, we're improving our patients' health and life. And another study, this is the image correlating that a diet containing various types of dietary fibers and resistant starches is going to support a more diverse microbial community. In fact, the participants who were studied here, it was those who ate more than 30 different types of plant materials per week had more diverse gut microbiomes. That's without probiotics or any fancy treatment. It was diet alone. So this is our patient's beta-glucuronidase. It is elevated, and this was from her GI360. So I'm going to work with modulating this. I want to decrease that, obviously. So high fiber diet, fruits and vegetables. You've heard me say that again and again. Improve digestion and elimination. This would also be a great place to use calcium D-glucarate to help the body to break down estrogen to not reabsorb it. Okay. We have finally gotten to chapter 9, which is our story resolution and treatment plan. You remember this, where I just listed, hey, these are the uncontrollable risk factors and the controllable ones. I know I'm going to go straight for here and get to work on creating a plan for her. I also am looking at her test. I'm pointing out, I don't like this elevated estrone. I don't like this. I want more 2-hydroxy, less 4-hydroxy. I'm really concerned. I want more weight on these back wheels here. I'm happy with this oxidative pattern. Arguably, I could do a little bit of modulation here, but really that's, it's new, kind of new to consider that. Aromatase, she's got a little bit more activity here that I'd like to reduce. I already pointed that out here, and just very little COMT activity. I think that's the biggest takeaway from this test as far as her breast risk. So this is her general treatment plan. I could give her this entire treatment plan minus the beta-glucuronidase without utilizing the test. So I just want to show you how you can take a step back and look at the uncontrollable versus the controllable risk factors and already come up with a beautiful treatment plan. And then as far as the test markers, those are kind of the fruits and vegetables, nutraceuticals that are what I consider the cherries on top. So for the estrogen metabolism, I'm calling this phase 0. I want to lower that unconjugated E1 in the urine. So I'm going to downregulate aromatase. And these are all the highlights that I had from earlier slides. I'm just pulling that into this slide. I'm going to do phase 3 improvement, then move to phase 2, then phase 1. Phase 3, I'm going to make sure she's having a bowel movement once or twice per day. Then I'll move on to supporting that COMT enzyme. I'm going to also downregulate CYP1B1, upregulate CYP1A1, downregulate CYP3,4A. So I'm getting more 2-hydroxy, less 4-hydroxy, less 16-hydroxy. I'm also coming in with NAC and resveratrol to be like a mop-up plan to control for some of those factors. I'm happy with this progesterone metabolism. I don't need to do anything here. She's preferentiating the 5-beta. So otherwise I would be avoiding or downregulating 5-alpha reductase. I also want to consider if I ever give her progesterone, I may want to watch this pathway and make sure she's not moving to too much pregnanes with oral progesterone, greater than 200 milligrams typically. She is preferentiating 5-beta reductase, so that's good. With her androgens, overall, they look great. So we don't need to modulate that. We're already having a plan to work on aromatase. If you're being real picky and you want to lower this, you can think about quercetin. Again, I'm avoiding licorice for her because of that hypertension. Intense exercise will downregulate this. I arguably feel like having a little bit more storage is protective. And I could upregulate CYP11B1 to move this a little bit more readily with vitamin D ginseng. So at this point, you probably feel like this here. We get to be an expert who knows more and more about less and less until we know absolutely everything about nothing. I think that's sometimes what these types of tests, you can go so deep down rabbit holes and think about it so linearly that you feel like, oh my gosh, I don't know anything anymore. The Hue Map test is a very detailed test, but I just want to remind you, be careful to not get too linear, too lost in the details. Lean on that summary page. This is how I start all my treatment plans. If you want to copy this, totally fine. I think this is arguably, you know, the most necessary thing for health to stay alive and then thriving in here. Breath, hydration, nutrition, sleep, all of that. So I'm going to copy this and start to put in those highlights that I used. So I'm starting with breath, adding hydration. Look how much nutrition improvement we get. We're addressing almost everything in this hormone metabolism case with nutrition. I won't read all of that and bore you to tears, but you've already seen it all. It's all just laid out there. I'm just pulling the highlighted pieces out. Okay. Movement, stress management. This is all working to reduce aromatase, to improve the gut microbiome, to lessen stress. This is, in my mind, the complete kind of holistic plan. The nutraceuticals, I do consider cherries on top once I've done that more foundational work, but things like diindolylmethane and resveratrol, NAC, magnesium, calcium D-glucarate. I will tell you, I have found supplement companies that create, you know, for this specific reason, supplements that have the majority of things you see listed here all in one capsule. So that makes life a lot easier. If you feel like something's missing after this Hue Map, do consider that there are complementary tests that can be done. We already talked about the GI 360. Certainly, if you need to know what's happening at the tissue level, salivary panel would be your go-to. Urinary neurotransmitters, so serotonin, dopamine, things like that. You can actually, the lab can pull from the same sample and test that. So that's really cool. The patient doesn't have to do any extra collection, but that's another wonderful thing. And we do have a gold standard test, which is the red blood cell glutathione level that you can take a peek at. So these are the take-home points. Gut health, proper elimination, super key to this entire story, probably where you want to start. I would treat in reverse order, phase 3, phase 2, phase 1. Come back and reassess the area of concern. For GGR patient, I'm really mostly interested in relooking at those estrogen and metabolites after about 3 months of treatment. Please don't forget to take a step back and look at the big picture. If you have that big picture plus the Hue Map interpretation, this can really lead to very beautiful story endings for your patients. Thank you so much for sticking with me through that. I will turn it over. I'm not sure if there's time for Q&A, but I will do my best.
Dr. Neville, we have all the time in the world for Q&A with you. That was an amazing presentation. I don't know about the folks who maybe have to hop off or already hopped off due to conflicting meetings, but you know, that was a fantastic presentation, and I'm very glad that it was as comprehensive as it was. And so with that, let's just go ahead and jump into just the Q&A. I go chronologically through this. So if you do have any questions, please use that Q&A button down in your menu bar, and we will go through as many as we can. And then immediately following the Q&A, I'll show you exactly how to order the Hue Map as well as any other tests from doctor's data directly through Rupa Health. So jumping right in, you started off by talking about things that would physically healthy and not promote cancer. This question is specific to alcohol, and how much alcohol is safe to not promote cancer?
Yeah, it's a good question. There's new research. I don't know if you've seen just kind of general discussions about this online recently and in kind of the medical forums. I don't know for sure. You know, we used to say, 1 to 2 glasses for a woman, I think was the consensus, especially red wine, so all the women were like, oh, great, and they're drinking their red wine thinking that's helping them. The more and more I see, it's the more alcohol you consume, the higher the risk. So whether that's 1 or whether that's 10, there's a stepwise consistency there. So
Absolutely. Yeah. And the old French paradox, the glass of red wine a day
yes,
helps.
yes.
Is something that I learned. So next question is, does the report give treatment and dosages of supplements?
We certainly have treatment considerations. Dosing is not necessarily given. And I think that's because, a lot of this research, some of it's animal studies, we're kind of like pushing the forefront, and we're really like venturing into uncharted territory. So to be fair, I think, I always start with food-based first. So if you're looking for very specific dosing regimens, sometimes the supplement companies out there have done some of that research, and you can just go, take a look at that. But no, we don't give exact dosing at this point.
Yeah, that makes sense. So this one is more of a technical question. So any feedback for women with high levels of 16-OHE1, but normal 2-OH and 4-OHE1? Are they just eating diet herbs that are inducing CYP34A or 3A4? Is it even a problem given the low 4-OHE1 and good methylation?
Yeah, I mean, I think that's an important point that's brought up. Is there appropriate methylation? Arguably, I don't want too much 16 regardless. I don't want 0. There is some research showing that 16-OH is important for bone health. So I don't necessarily want to bring that down to nothing, but I don't want it elevated either. And green tea is usually my go-to to try to dampen that CYP34A. And also green tea you saw was a biphasic modulator. So I'm giving that to the body, letting it find, neutral. I think it's great that there's not high 4-OH, and that's being methylated. That's also going to bode well. So you can see where this gets to be somewhat of a dynamic. It's not yes or no. It's not a linear thing, but she's probably in the middle. You could reduce risk still.
Perfect. So this is a callback to the phase 1 detoxification slides that you were going through. In one of the slides to slow detox poisons like charred meat and smoking, is there other ways, or what other ways are there?
Oh, to slow that down? Well, yeah, you saw, go back through those slides because there are ways to slow that down with natural substances. So like berries will do that. Green tea will do that, I believe. And there was actually a study on a product that's out on the market. I won't say the name, but they literally studied, this was a combination of a bunch of different botanicals, basically ginger, rosemary, this is all in a capsule, and that was shown to slow that down.
So the next question is, can you apply a progesterone cream on breast lumps?
Yeah, I've heard people doing that quite a lot. My only hesitation, and I love the idea of that, like put it, like the ocular progesterone, let's put it right where the body needs it. My only hesitation is, as a laboratory, we've seen pooling, because progesterone is so fat loving. If you place it over fatty tissue, it tends to like pool and stay there. So arguably in that case, maybe you want that. Usually for me, I'm thinking whole body. And so I want it going to the brain, the breast, the uterus, all of those places. I don't want it to pool. I want it to be released at consistent amounts. So if you were to do that, I don't think there's any problem, but I would caution you that if you're doing testing and you're looking to see for the dosing, you could see variations in the levels because of that inconsistent kind of release. And it might be pooling right there. So
perfect. And kind of a follow-up to that one, is it safe for men to use progesterone?
I have used progesterone in men where I'm worried about BPH and prostate cancer in order to protect against estrogen proliferation, which is arguably more the issue in prostate cancer than testosterone, So yes, much lower dosages than women. And I would certainly follow, their PSA and how they're feeling and all of that. But yes, there is research on that.
Perfect. Does the Hue Map test replace the older salivary hormone panel and urine estrogen metabolites?
So the Hue Map is the urine parent, the unconjugated in the urine, and the metabolites. I would not say that it replaces salivary hormone. Those two are different sides of the story. So you've got what's active at the tissue, what's the starter material versus what's leaving the body and what pattern it's leaving the body, if that makes sense. So neither replace one another, but they are looking at just two different sides of the story.
Perfect. And then this is a question that was given by one of our newer practitioners. So for practitioners who are new to just the functional medicine landscape, or even just interested in using the Hue Map or doctor's data tests in general, why like, what separates doctor's data and the Hue Map specifically from other tests that they might find on the market?
Yeah. So we did a lot of R&D for years before releasing this test. Our test is using a liquid urine. So a little bit different than some of the companies out there. We found that to be the most reproducible and accurate data. We have some additional analytes. So we're looking at the methylation potential of not just estrone, but also estradiol, which interestingly can give you some more insight. It doesn't always correlate. So if you have great, methylation in one part, doesn't always mean there's going to be great methylation on the other side. So I think it gives you a little bit more of a specific look into arguably one of the most important parts of this whole story. And really, I think, we've done a lot of work to try to make that summary page and that second page, like just at a glance, dynamically reported so that every patient's report looks different. You're going to be able to see, right off the bat, what is, a higher level, what do you have a lot of, an abundance of versus what's low, and just keep it efficient for all of us, because that's what we need. I think it's also great because you can add on neurotransmitter testing to the same sample, and you just have access to DDI. We have over 75 different profiles, so we've been in the game for 50 years. It's our 50th anniversary. We've got a lot of tests to offer you if you feel like, you want a complementary component to HuMAP too. So
perfect. And then last couple questions here is how does tamoxifen alter results?
That's a good question. So I don't always know. I think it's like a fingerprint, right? Like it's going to be different for each individual. I can't say that there is a specific pattern that you're going to see every time. And that's why I think the test is so helpful, because I don't always know. I tend to steer people away from saliva testing if tamoxifen is being utilized, because we know that it doesn't matter what the level is showing at the tissue site. The point of tamoxifen is to make that inactive at the tissue site. But how it's kind of moving through the body and in what pattern, what direction, I think that's still a valid question. And I still think you potentially could use urinary testing for that. And, maybe you add on resveratrol, and that's, protective and successful in breast cancer anyhow, just making sure you're not, getting in the way of the tamoxifen.
And then the final question we got here would, if you could pull up the slides again, back on slide 77, there's a very specific question. Could you explain the reference to the I on the oral versus topical progesterone slide?
Sure. 77. Oh, wait, where'd it go? Yeah. This is the reference you want right here?
Potentially. It's from Dr. Pikunas in the chat. So potentially either 78, 77.
Yeah, I think this is the ocular study. I think this is what
Perfect.
you're talking about.
Yeah, so they're asking, could you please explain the reference to the eye?
Oh, to the eyeball? I was thinking eye. Like the eye. So, this is what I'm doing here is just kind of reminding you, and after years of looking at all this research, I get nervous when we're using oral progesterone, thinking that it's going to reach, the tissues, the eye, the brain, the breast, wherever we need it to, the uterus, because it's virtually insoluble in water, as the study is showing you. It dissolves in gastrointestinal fluids slowly and incompletely. So it means that it becomes very ineffective right away. And also the majority is going out in the urine and the stool. Not a lot of it is getting to the actual tissue. So I'm just showing you that this is an example of this, where they needed to use a topical, and specifically they were using, interestingly, ocular progesterone to really get the benefit that they needed at that location. And I think it's just showing that there's so many different ways that you can look in between the research to really question. I just don't think that oral is the best way to protect people from proliferation of estrogen. I
Amazing.
hope that makes sense.
Yes. If
And
it
that's
made sense to me, it made sense to the practitioners.
okay.
Perfect. Well, Dr. Neville, thank you so much. This is genuinely one of the most in-depth, comprehensive, and just interesting all around classes that we've had here. So thank you so much. I know this takes a lot of time to put together the slides. So thank you, the team or over at Doctors Data for joining us today. Do you have any final thoughts that you want to get out there?
No, I just thank you for being here. It's an honor. I love Rupa Health and, excited to be able to talk to all the practitioners here who are utilizing Rupa. But, I think, again, the biggest takeaway that you saw me try to make, and I hope I did it gracefully, was that it's a super detailed test. But I think in the end, it's less overwhelming once you realize, take a step back, you're talking about gut health. All of those things are going to improve hormone metabolism. So you can get really detailed and linear about it, but you can also kind of, take that big picture view, and you're still going to be massively helping your patients to do all these things. And you can do so in a pretty efficient way, a multi-mechanistic way, by utilizing natural therapies. So
I love that. Perfect. Well, Dr. Neville, thank you again so much. You're welcome to hop off. And for those of you who do have about 5 minutes, what I'd love to do is actually show you how to order this test directly from Rupa Health. So I'm going to go ahead and share my screen, and we can just jump right into it. So for those of you who don't know, my name is Adrian Martinez. I am the head of practitioner partnerships here at Rupa Health. And really what my role here is, and part of my role is to be an educator and to educate practitioners about Rupa and who we are, what we do. So what we are is we're a functional medicine platform. We're designed to make life easier when it comes to ordering and managing functional lab tests. The way that we do that is in a few different ways. What we've done is we've brought on over 30 different labs in one place. So now, instead of having to go to each individual lab like Doctors Data or Genova or blood labs, you come to Rupa Health and you have access to everything in one place. So now I can come here and I can order from all those labs without having to go to each individual portal to place all those orders, without having to go to each individual portal to manage all my results, right? And so the idea here is to streamline efficiency when it comes to lab testing. Beyond that, to make life easier for you and your team is we've built out an end-to-end patient solution. So as soon as you place that order on Rupa Health, we can take it from there. We'll go ahead and reach out to your patient. We can manage billing directly with your patient, or you have the option of paying for the tests yourself. We'll send over FAQs and instructions to the patient, walking them through how to take the test. Additionally, we'll handle any support questions they have, as well as even things like coordinating phlebotomy, as well as specimen issues if they arise. To place an order on Rupa Health, it's simple. We just need your patient's first name, last name, and email address. From there, we collect everything else directly from the patient to make life easier, not only for you, but to ensure the accuracy of the patient's information. So what I did is I go ahead and put in that information for my patient, and now you're seeing the orders screen. So up at the top here, you can see custom bundles. So we can actually create custom bundles, sets of tests, sets of blood panels of any one of the labs that we work with. That way it's one click, and those kits will be added directly into my cart. Below that, I can create a favorite list. So a favorite is just an individual test. I put a little heart next to it so it appears at the top. And so again, I can order these individual tests that I commonly order from any one of the labs right here at the top. So I can order that Hue Map from Doctors Data. I can order the GI 360. I can order from Great Plains or Infinite Allergy or any one of the labs just within a matter of seconds. And if I am looking for a specific test, I have access to the whole catalog down below. From there, it's as simple as clicking send a patient. And that's how you're able to order from 30 plus labs over 3,000 different tests within a matter of seconds. What's great about Rupa Health is it's free. It's free to sign up for, it's free to use. The only time that you will pay anything is when you want to pay for an order yourself. So let me explain that a little bit. So the way that our pricing works is we offer wholesale practitioner prices. What I mean by that is we offer the same prices that you would get having an account directly with the labs. So you'll see here that most labs offer two prices. They have a practitioner price and they have a patient price. That patient price tends to be substantially more expensive. So through Rupa, not only are you getting that same price that you would get be working with the lab directly, but your patient's also getting that lower price. The way that we generate our revenue is simple. We charge a 7% processing and ordering fee on each order, and that's it. And that's paid for by whoever's paying for the tests. So most of the practitioners we work with have us just bill the patient directly. in which case the patient will be the one absorbing that 7%, in this case, $10 plus a $4 shipping fee from doctor's data. And that's it. Rupa is free. The only time that you would pay for anything is if you decide to pay for the test yourself. But if you're having Rupa manage the billing directly with your patient every order, then you will never pay a dime to Rupa unless you want to. Pretty cool, right? From there, you can add notes for the patient. You can add notes for Rupa. You can add ICD-10 codes as well. We don't accept insurance directly, but if you want to add ICD codes here, you can do that, and we'll walk your patient through how to create that super bill to submit for potential reimbursement. But again, if nothing else, it's as simple as clicking send a patient. So what happens once you click send a patient? Let me walk you real quick through what the patient experience looks like. So as soon as you place that order with Rupa, we'll reach out to the patient. We'll ship the kits directly out to your patients as well. So no longer are you going to have to stock kits in office and worry about them going bad. We'll go ahead and drop ship the kits to the patient for you. We'll send out instructions and FAQs. We'll check in and follow up with the patient. And then from there, you're notified as the results come in. So here's what that looks like. When you press send, your patient will receive an email that says this: "Hi, Joshua, Dr. Jordan has ordered these tests for you." We'll introduce who we are, and then we'll actually highlight the different payment options that we accept. So one thing that's really important to call out is that not only can we accept credit and debit, but we can also accept HSA, FSA, as well as we can even set up a 3-month interest-free payment plan with the patient. Let me repeat that. We can set up a payment plan with your patient, interest-free, spreading that payment and cost out over 3 months, and we'll send those kits out to your patient after the very first installment. So what this does is it makes these tests more affordable for your patients, allowing you to be able to better treat them and allowing them to get the treatment that they need. Over here, you'll see that we collect all the necessary information to complete the order. We'll break down all the costs necessary that they have to pay. Everything's transparent. If you decide to pay for the order and manage billing separately with your patient, nothing changes in terms of the patient experience. We'll still manage that end to end. The big difference here is that we're not going to show the cost of what that was. Okay, Stephanie, the cost of Rupa is free to sign up for. It's free to sign up for. The way that we generate our revenue is there's just a flat 7% processing and ordering fee on each order, which is paid for by whoever's paying for the tests. Oh, for the DDI test. For the Hue Map, it's $149.25 on Rupa Health. From there, we'll reach out to the patient to let them know that the tests have been shipped out. And then we will go ahead and send over an email that looks similar to this. This breaks down all the instructions, all the FAQs. We'll help coordinate the phlebotomy if necessary. And then from there, you can see all the instructions that we'll send over to the patient as well. If the patient has any questions, they can reach out to our team and we will facilitate any support questions. And again, just to reiterate, we will handle any support as well. We'll handle any specimen issues that come up, any retesting that's necessary. We'll coordinate that directly with the patient in the lab. You will be able to, be in the know, but you don't have to be involved. And if there's a blood draw required, we will help the patient coordinate that as well. And finally, you're alerted as the results come in. Yeah, so $149.25. So what does that all look like in terms of just management, right? You send these kits out, patient gets taken care of. How are you managing all your orders? Well, you actually just do that right here in the main dashboard. So I can click into any order here and see exactly what's happening with my patients. I can search by patient. I can even filter by the status of each order. And you'll see in this example here, this is 4 different kits from 4 different labs. I have everything tracked in one place. So I can hop in here and I can see, for example, when the sample arrived at the lab, when I can expect those results to be in. And once those results are in, I can just hop in, I can download them, I can send them to my patient, I can schedule a clinical consultation with the lab as well. So if I need some assistance interpreting the results, I can hop in here and schedule some time with that lab. And I can even view the requisition should it be digitally available. So what's really great about this, again, is the time savings involved. I think the most valuable resource that any of us have is time. And if we're able to save you hours per week, per month, that's value, right? At the end of the day. We even integrate with a few different EHRs. So if you're working with Practice Better, Elation, or Optimantra, with a few more to come, you can actually have these results directly imported into your EHR automatically. There's a lot more EHRs that we're in talks with as well. So that's by no means the end result. And finally, what I want to show you here is just settings. So Rupa Health is a platform that's not just for solo practitioners. We can actually work with clinics of all sizes. So we can work with multi-location clinics. You can actually invite team members to join, invite your staff if you have an admin, right? And they can all hop in using their own specific login to order tests on your behalf. And then even phlebotomy, right? If I want to hop in and see what phlebotomy options are available in my area, I can actually do that as well. And then the last thing I want to show you, y'all, is Rupa University. So you're actually all a part of Rupa University right now. Rupa University, which I'll actually add the link for in the chat, is the educational component to Rupa Health. So these types of live classes, we actually host these every single week, every Wednesday, usually at the same time. Next week's is actually on a Tuesday, but we partner with our labs to come in and give conversations about these different tests that are offered. And generally, of course, the most popular tests that are offered and how they can be applied and used within clinical practice. So if you are interested in joining these, we offer these every single week. These are free to join. We always record them and upload them as well into this catalog here, along with the slides. So you can see we have this one today, and we have a couple more coming up in the next few weeks. We're actually booked out through the end of the year. So every single week through the end of the year, at very least, we're going to have one of them. And if you're interested in more of a deep dive, we even offer paid options. So if you are interested in learning a little bit more about things like the female hormones, we do offer boot camps, and there's much more topics to come. We have a Lyme boot camp on the agenda coming up as well. So check these out, all available, rupauniversity.com. The last thing here, y'all, if you do have any questions, I'm going to go ahead and share my information out. So feel free to reach out to me. I'm going to go ahead and follow up with y'all later this afternoon with an email. But here's my contact information. If you need anything, feel free to reach out directly to me. This is my phone number as well as email address. I'm more than happy to set up some time with you to walk through Rupa Health. Now, some logistics on Rupa at this time. Currently, we only operate in the US, and you do need to have an NPI number in order to sign up for Rupa. We are working on both those, but currently you do need to be within the US. So we don't operate in Canada, unfortunately, yet. And you do need to have an NPI number in order to sign up. We are working on a program called physician authorization. So if your license type does limit you in your ability to order labs directly, that should be resolved very soon. We're working with an organization that will allow us to order from, will allow practitioners to order from any lab, independent of your license type. So we're very excited to roll that out. Again, my name is Adrian. Thank you so much for joining us this afternoon. I'll be sure to include this recording. It'll be at the end of the presentation as well. Very excited for y'all to be joining us today, and let me know if you have any questions. We can go through some Q&A. So to sign up for access to Rupa, should we email you directly? Go ahead and reach out to me directly, and I'll go ahead and get you signed up. Or you can just go to rupahealth.com, and the sign up process takes 2 minutes. But I'll go ahead and keep your information, and I'll keep an eye out for when you sign up, and I'm more than happy to set some time up with you to walk through the platform. So even if you sign up independently, reach out to me and I'll set some time up with you to chat. Awesome. All right, everyone. Well, enjoy the rest of your Wednesday. I am very excited to have some of y'all on board with us, and hopefully we'll see you next week. Have a great rest of your day.